All right, since we now have a technical difficulty, I don't have a system flip the slide for me. So my name is Nai-Ling. I started my nursing career studying in Taiwan in the 1990s late. And I started as a cardiology nurse there, where I worked in the 5,000 beds unit. So cardiology is about just 100 beds. At the time, it was the early stage of PCI. There's no drug-eluting stents, only PA, like the blue model stent for the lesions. Later, they started to have a stent. So anybody who was studying a nursing career in the 90s, raise your hand. All right, you must know about this. We have few, so we can have some connections. So in that time, there's no, well, at least in Taiwan, there's no automatic like pressure on the femur. It's all femur access, there's no radiatory access. And you always have to check that pulse every 15 minutes because sandbag eventually cause arterial injury, then we call vascular surgery. So that's where I started. And then after a few years in, I would like to pursue more advanced treatment for heart failure. So I came to the United States to become a nurse practitioner. And more focused on primary prevention. So I graduated from Columbia University with a dual MP degree. Guess what? 2 years later, they merged it in one. So, okay, fine. And then I moved to Washington State and then started my nursing career there. Oh, now I can see this right here. In the last 2 decades, in my opinion, the cardiovascular surgery had 2 breakthrough changes. One is transcatheter valve options. They started clinical trial in 2008, official transition into commercial use in 2011. Now using many types of valve intervention, just the earlier we say, TAVR approach, mitral clip, tricuspid valve clip is on the way. And the other breakthrough is mechanical circulatory support systems. It starts with LVAD. Only have like one brand, LVAD, HeartMate 2, 3, and Heartware went into the market and later got pulled out. So now it's more toward to temporary device in the mechanical circulatory support. So I really admire those ICU nurses. 20 years ago, you have none of those, but you need to know all of this plus ECMO. So in the later talk, you have some anesthesiology perfusionists talk about that. Later, you will hear more about transcatheter option in the last section of today's conference. And then I developed some interest, wanted to know more about the health system. United States health system is very unique. It's highly regulated by law and also the insurance policy. So I graduated from University of Washington, got a master in health administration in 2020, and moved here in 2002. So this is my brief career. Next. So today's talk will cover what is ERAS, and what's ERAS transition in cardiac surgery. And we do have a system-wide ERAS approach at Houston Methodist. We will share a little bit about that. And hopefully you are part of the team and also bring your patient into the team. So what is the ERAS? This have to start with, we have to talk about is Dr. Kelblett in 1997. His primary research is interested in surgical stress to patient recovery. So in his mind, he introduced the concept of multidisciplinary approach to minimize surgical stress to the patients, hopefully improve their surgical outcomes and result in ultimately shorten patients' lingo state. And in his introduction, there are 3 concepts, breakdown in 3 phases. Phase 1 preoperatively, the other one intraoperatively, and then post-surgery. But he's a general surgery. His focus was on colorectal. So that will be slightly different when we transition into cardiac surgery. So preoperatively, he said, we need to monitor patients' nutrition status, and then minimize the fasting stage, and also patient education. They know what they need to do as soon as they wake up. During the surgery, he emphasized on minimal invasive surgical technique, and also efficiently pain management. And then the last one was maximum of fluid management. The later, when the patient wake up from the surgery, you want patient out of bed right away. start to eat, and the last one is minimize the drain. So this concept will spread out to the colorectal surgery, gynecology, and orthopedic surgery. When you go into cardiac surgery, it becomes more complicated. In the cardiac surgery in the operating room where a perfusionist, patient need to go on heart-lung machines. So how do we optimize this with a multiple disciplinary approach to reduce the surgery stress to the patient? In the end, we can actually help patients to recover from the surgery fast. So if we follow his concept, there are 3 stages: before the surgery, in the surgery, and after the surgery. So before the surgery is very important to have patient engagement and select the right patient going to the surgery. As the previous talk, now we have more options instead of just bring patient to the operating room. And then we also have to understand what are the chronic illness patient might have that we can optimize the treatment and get them the best condition to go into the surgery. So in this case, we're talking about elective surgery. We're not talking about patient coming with a helicopter landing in the ICU, the next day going to the surgery. There's no time to optimize the patient. At that moment, we are actually trying to save patient's life. And then interoperatively, we have different approaches. Eric Arendon is our service program manager. He has been working with our ICU floor to optimize some standardizations. And then after the surgery, it's the same. Early extubation, make patients start to eat, and pain management as the approach we have right now. So in the next few minutes, we want to talk about how do we get patients engaged, what's the current risk model that we have to provide more objective assessment of understand patients' risk, and then what's the frailty means, and how do we manage the chronic illness. Oops. All right, patient selections. Anybody watch this movie before? The one on the right is Paul. The one on the left is Master Monkey. So last night when I was preparing this talk, I asked my son the same questions. If he doesn't know anyone and you're going to pick a patient to go into the surgery, which one are you going to pick? Which one would you pick? The one on the right, raise your hand. Who will vote for Paul? Raise your hand. Nobody. All right. Who will vote for Master Monkey? Raise your hand. All right. So my son's 15, so he watched all the series of Kung Fu Panda. So he brought out a very interesting perspective. He said, if you look at Paul at the beginning before he became a Kung Fu master, he's not a surgical candidate because he cannot make even do the stairs. By the time he put his head on, he really can be a good surgical candidate. I was like, oh, I didn't notice that difference. So on the surgical assessment part, it's important not only look at the BMI, I guess everybody looking at his BMI, but also understand patient's motivation and engagement. So I'm going to share a very short story about patient engagement in my career. A few years ago, we met a patient, he's in his 78-year-old. Slightly looked like Paul. Walk into the clinic and told my surgeon and say, hey, doc, I have this aneurysm I haven't followed for 5 years. Now the size is like 6 centimeters. The surgeon looked at him and said, well, we talked about this 5 years ago. What happened in the past 5 years? That was way before the COVID, so there's no COVID missing follow-up excuse. He said, well, you told me you don't know how the nature progress of the aneurysm, so I guess I can get by with it. Who knows, it grew. All right, so now we have a 78-year-old gentleman, 5 years later with an aortic ascending aneurysm. There's no PCI options. So now it's really truly on surgeons' patient selections. So the surgeon looked into his eye and say, so now why do you want a surgery? On a surgical consultation, ascending aneurysm patient is the most difficult one to convince them into the surgery. Why? Because there's no pain. There's no activity changes, impact on their lifestyle. So when I'm talking to a patient, you have no pain, You don't know what's going to get out of this. By the images said you might die. That's basically how we tell the patients. So the patient said, look, doc, you see this lady right next to me? Is my beloved wife, second marriage. And I have a son, he's in high school. So I want to see him go into the college, 2 more years, but I don't think my aneurysm can wait for 2 years. All right, so he got the motivation. Is the patient engaged? What does he want? He wants the surgery. Why? Because he wants to see his son go into college. The surgeon look at him and say, okay, but here's what you have to do. I want you to walk 1 mile every day, and then when you do that, you call me in my office and schedule for the surgery. And on top of it, we're going to talk about what the patient has. And he has also, 5 years ago, he did not have atrial fibrillation. 5 years later, he has AFib. Now we have to manage. So in the end of this presentation, I'll tell you what happened with the patient. So now we have patients. And on the Society of Thoracic Surgeons also try to help physicians and healthcare providers how to better assess the patients. We started with aortic valve and mitral valve risk models. In the risk model, you can enter patient's information, primarily in 4 blocks. First block will be patient's age, gender, and race, and BMI. The second block will be what's the patient's current medical-related risk, diabetes, hypertension, immunosuppressant. If you work in a TAVR, you do STS every day. So basically 1, 2, 3, 2, second block. The third block is assess patient's LV functions, New York Heart Association class. The fourth block is more about cardiac-related issue, related, for example, arrhythmia history, coronary artery disease issue. You put all of this, you generate mortality, long-term complication, and short-term complications. So most of them will use this to predict patient's mortality and decide should we actually bring in a patient to the surgery. As we said earlier, the transcatheter option is more progressed. Now we are tricuspid valve options. So now you come out with the risk model, we do this one. And now we also have patient previously going to transcatheter aortic valve patient. Now they're needing a surgery. What's their risk? They come up with another model. Then the last two are a combination of double valve, single valve, without coronary bypass surgery. So if you wanted to know your patient risk, it's on the website. Just search the keyword STS risk calculator, it populates. Then under resources, you can find this risk model. Then another thing is actually important to assess the patient going to the surgery called Frailty test. The frailty means the decrease of physical conditions and then increase the vulnerability of decline after the stress. And surgery is a stress to the patients. And then according to the Frailty assessment tool, you have 5 domains, which is not widely translated into the STS calculation. One domain will be the walk speed, whether they have unintentional weight loss, weakness, or physical strength. All of these, most of them are captured into the previous STS calculation risk model. The only thing we haven't calculated is the walk speed. So this becomes one of the assessment tools we'll use before patient going to the cardiac surgery, and then we'll calculate how many seconds patient walk in a 5-meter walk. There is a new proposal of, if we have patient sit on the chair, then you do have them stand up without supporting anything and calculate 5 times and try to understand whether physical strength and then whether they are frail. This was just a short video it published a few months ago at the STS website, but officially they have not changed this testing yet. So in the future, you might see you have to do a test with the patient sitting on a chair and then stand up and sit down 5 times. That's why. All right, now we know the patient is engaged. We check everything, patient risk is acceptable. Now we have to look at what's going on with their past medical history. So it's important to understand whether the patient has a TIA or stroke and obtain a non-contrast CT scan to fully assess. Primarily for cardiac surgery, we put patient on heparin drip during the cardiac pump, during the operation. If the patient has bleeding, that is not really good for the outcomes. On the primary assessment, smoking is a big one. We will try all the best, try to ask patient quit smoking, as little as we tell them 10 days. And then it's actually better if a patient gets into the hospital, there's no way they can smoke. But we cannot admit the patient anymore because it impacts our legal state. So we tried everything we could to reduce or to tell patients to quit smoking. Another thing is to understand whether the patient has sleep apnea history. It's highly correlated with atrial fibrillation, and then optimize their COPD and asthma management. And then on cardiovascular one, since we need to harvest either radial artery or vein graft to know whether they have a peripheral artery disease, and then venous insufficiency, they will determine where the graft is. And then on the medication preoperatively, if patient has a coronary artery disease, we'll continue their aspirin 81 until the day before. And beta blocker must be taken within 24 hours and several ACE and ARBs 48 hours before the surgery. And then carotid artery disease is actually kind of hit and run. Recently, we just had one patient had bilateral of 99% stenosis, no symptoms. And we found out this just prior to coronary artery bypass surgery. The nurse sitting back there and looking at me and said, yeah, that's our patient. So that new finding immediately changed the surgery plan. So don't forget, if patients have coronary artery disease, always assess whether they have a carotid artery disease, because disease usually is systematic. All right, our best friend, diabetes. Without diabetes, there's no such renal insufficiency, there's no coronary artery disease. Our goal is really try to optimize the patient with a hemoglobin A1C less than 8. Do we always achieve that? Not always. Primarily because patients, usually by the time they are symptomatic, we don't have time to optimize. So we actually try to get endocrinologists engaged, helping us to manage the patients and try to approach, we say approach 8, but not always at 8 or below. Now the next one is the new medication, the new kids on the block that led us so many case cancellation last year. SGLT2 inhibitors. Do anybody know about these medications? So this one, it was initial approval of type 2 diabetes management. It also showed the benefit of heart failure on their fluid management and also LV functions improvement. So now it's widely used. You probably can see this one everywhere. So make sure they must stop at 4 days before. And the reason for that is it does, the key component is not the 4 days. The key component is if patient is on this medication, not eating and drink, the complication will be patient with severe dehydrated. We're gonna have acidosis happening during the surgery. So that's why it's important to have patients stop 4 days before the surgery. But if you have a patient with a very short cases, just 1 hour, is that necessary? But right now, anesthesiology will stop you and cancel the case. So it's ongoing discussion we are having with the anesthesiologist. But cardiac surgery usually only have a 1 hour case, so we still have to stop 4 days before the surgery. The last one is, before patient go into the surgery, we want to know whether they have a UTI, BPH, and then we help with catheter management. And then post-surgically, AKI is a highly independent predictor for the outcomes. So age, gender, LV function, and then whether patient is well managing the diabetes, those would be very important to know. So since we have these ERAS, what is the current approach across the whole system that we have? So last year, Dr. Minkin, the thoracic chief, was asked to lead this committee, which is primarily starting with the physician engagement of how we can optimize and utilize this concept throughout the whole system, partner with the anesthesiologist. In this one, they currently has started with a patient education video through the text systems. So if you put the case request in, under the case request under Epic, there's this is a patient an ERAS candidate. If you click on say yes, patient will automatically receive the following video to walk them through what is ERAS mean to them. So I'm going to show this clip to all, so you know we are trying to get patients in part of this as well. Well, since I cannot play this one now, I will email to you after have Emily help us to email this one out. So in the ERAS video, it walks patients through how to optimize their nutrition status as I earlier stated. The NPO strategy has changed from midnight to 2 hours before the procedure. On the original ERAS protocol, you want patients to have carb-loaded drinks. On the cardiovascular surgery right now, we only have patients do clear liquid diets. That already caused confusion. Patient come in with one of the Teva case with Frappuccino because he said, I can not eat and drink 2 hours before the procedure, but Frappuccino has dairy in it, so the case got canceled. So there are so many confusion when we explain to the patient what it means by having a carb-loaded drink 2 hours before the procedure. To make it streamlined and easy for the patient, just water right now, for now. So in that video, walk patients through this and also tell them as soon as they wake up from the surgery, the goal is for them to get out of bed immediately. The next day, start to walk at least twice. And then before the surgery, they'll also ask patients if they could, they should try to walk at least 1 mile per day before the surgery to increase the activity in yours. With this, I would like to invite you all to subscribe DeBakey Journal and also subscribe our DeBakey YouTube channel. It has almost weekly updates for you all to keep in current, and primarily is led by the physician. I'm going to step out so everybody can subscribe. All right. In the end, before I go into Q&A, I want to tell you what happened with that 78-year-old gentleman. So he went through a surgery, stayed 5 days longer with ascending aneurysm surgery. His AFib was well managed. He did not go home right away. He went to rehab for about 3 weeks. By the time he came in, he walked in with a walker with his wife and told the surgeon, I said, look, I told you I'm going to do this. I'm working for you. So it is important to have patient engagement throughout the whole process. The worst scenario is the patient come in, don't know what's going on, wake up with LVAD. They will never do too well. Well, you need to convince the patient. It takes more nursing time to bring it on board. All right, up to here, any questions? So the transcatheter valve patients. Oh, so the question was, do we ask transcatheter valve patient, like TAVR or transmitral valve patient, to walk a mile before the surgery? In my opinion, we shouldn't, but we should encourage them to maintain their activity. The reason for that is they're not a great surgical candidate to start with. And how do we optimize in their post-surgery recovery? They need to know, even if it's 36 hours procedure, meaning hospitalizations, but their overall is primarily limited with all the symptoms that valve disease has. Just like you can turn a question around, like for the heart failure patients, before they go into heart transplant, do we ask them to walk a mile? We don't. But it's important for them to, after the surgery, have to record how much they walk every day. The goal is for them to do a little bit more every day, and then after a month, they do way more than before, like Mr. Paul. Before he became a warrior, he cannot do anything. Now he can. Any other questions? This is a good one. Oh.
Can I see the last page or the one with the QR code?
Oh, you want the QR code? Any other questions? All right, I forgot to thank Emily Kell and Amine who organized this, and then it's difficult to squeeze the PowerPoint from all the speakers. They did a fantastic job. Thank you.